out of 3 have experienced incident of abuse or harassment in the course of 1 year's work.
Wow. Since all the efforts have been put up, has the number of abuse and violence gone down?
So,
why are hospitals always so cold?
we have a whole basement network.
Whoa. Is there something that you would know about running hospitals that doctors might not notice?
You know, actually,
When you think of hospitals, you probably picture white walls, long queues, and maybe a very distinct smell of antiseptic. But what if I told you there are secret tunnels, secret protocols, and more? So today we are going behind the scenes to Singapore's hospitals with the CEO of Khoo Puat Hospital and Yishun Community Hospital, esteemed psychiatrist and adjunct professor at the Lee Kong Chian School of Medicine. Please welcome Dr. Chua.
Wow. Hello, welcome to the show.
thank you, thanks guys. Okay, let me just say first of all, I'm still a doctor, so I'm a psychiatrist, and I still see patients 1 day a week.
Oh.
So then the rest of my time is a hospital CEO.
Wow, imagine to be a patient, damn shook. You see who junior doctor? I see the CEO.
Yeah, but then they can also say, I want to complain to the CEO. Then you are the CEO, right?
Let me see your manager.
Why don't you do something about it? The hospital, your hospital, right? So yeah, so
One thing that I really want to ask, why are hospitals always so cold?
actually, we don't need to be so cold. Okay, to some extent, okay, I'll tell you, operating theatres, right, are the coldest place in the hospital.
Yeah.
And it has to do with infection control, and it has to do with keeping the temperature low and humidity low as well. So we don't want to be dry, because sometimes they use a lot of equipment and machines in the hospital, and sometimes if the temperature gets too high, you get condensation and things like that. So there's a problem there. You don't want water contamination. But we also realize that actually we don't need it to be so cold. So in fact, in our hospital, we're trying to be green and sustainable. We try to increase the temperature slightly. It's good enough for infection control. It keeps patients safe, but at the same time, it also doesn't freeze everybody up. Everybody wearing layers and layers of it. So in fact, we're trying to experiment on some of these things.
I've also noticed, right, that like there are different people wear different colored scrubs. Is there like a system to it?
Yeah, so there is a system. So doctors have doctor scrubs, and then nurses have scrubs, and then with our allied health professionals, the therapists, physiotherapists, and they are all coloured, and they have got slight differentiation. So actually, it helps us, helps the patients and the family members to recognize who they are. So actually, there is a code system. So it's not like anyhow everybody wears everything. It's comfy. It's easy for them to move. We make sure that design them according to the specification. So you see, very strange. These pajamas got lots of pockets.
Yeah.
So doctors put a lot of things. We also have made sure that the shirts are above the elbow, because we want to have this system called bare below elbows. It's all about infection control. We realize that. So really, when you wash your hands and you touch patients and you clean your hands after that, if you have got sleeves, right, your sleeves can pick up things. You also see nowadays doctors don't wear ties anymore. So we realize that ties are one of the dirtiest items in the doctor's wardrobe.
You never wash them?
You never wash them, and exactly. And then you wash your hands, you wash your clothes, but the tie has touched all different parts of the bed and the patients accidentally, and then when you bend over, so really that's infection. So it kind of has narrowed down to the scrubs.
There was a study that was done where they asked patients, right, doctors in different coloured scrubs, who do they trust more? And then the result was that blue and green come off more trustworthy, while black can be perceived a bit more negatively.
Okay.
May well be, yeah.
If you are pediatrics, maybe light pink can be suitable, according to Google.
So I've seen pediatric scrubs with animal prints and things like that. So they make it friendly for the, so like you see another auntie in pajamas walking around with you in your ward.
So as CEO, right, is there something that you would know about running hospitals that doctors might not notice?
Doctors don't notice. Well, I think they should notice, because actually the whole hospital system is there to support the doctors and nurses and clinicians so they can treat the patients. But behind it, right, there's a whole, I guess what we call operational effort, as well as hospitality services. So in order for the doctors to treat the patient, right, make the diagnosis and then recommend treatment or even operate on patients, right, we got to make sure the patients get there. We got to register the patients. We got to make sure that when they are there, there's a bed available for them, right? So all these logistics has to be there. And then after the patients get treated, operated on, whatever, right? When they go back to the ward, there is food for the patients. The beds are comfortable and clean. So all these things have to be, that's all going on in the background.
Even though it sounds like there's some synergy, right? To me, I would imagine that you spend all these years learning to be a doctor and suddenly now to run a hospital, it feels more admin. It feels like a new set of skills.
Yeah, so it's a long journey, right? I've been a doctor and administrator for quite a long time. You figure out how you treat patients. You know about medical conditions, what are the best treatments available, how to recommend them, make sure your patients get those treatments, right? That's the doctoring part. Then later on, you start to wonder about all these things behind. How did the patient even get to your, when come some days, patients have to wait a long time. Sometimes patients get their appointments earlier. Is that something to do with the booking system, or when they called in, right? When there's a query between our clinic sessions, did someone answer your call? Does the hospital have a contact center? Is it supporting patients in between? So you kind of get all these things. Over time, right, you have to figure out then the medication delivery. Previously, when I first started joining healthcare, they pulled the medicine out of a drawer and then they just serve the patient based on a piece of paper that they saw. So we actually have a computer system now. So in Singapore, sometimes there are two aunties in the ward with the same name, Lee Amoy, okay?
Tan Agik.
Okay, and then so you ask, are you Lee Amoy Tan Agik, right? You say yes, right? Then I gave you Tan Agik. That auntie also Tan Agik, right? So we ask for two identifiers actually. Then when the patient is given the medication, right, there's a system to double check the patient's identity, the medication's identity, it must match, and then they do a lot of scanning and it clicks. Then basically there's a record the patient has got the medication correctly. So it's not like dim sum, you just serve from the trolley and then the raw order, just take back sort of thing. So behind the doctoring and the providing of healthcare to patients, there's a lot that goes behind.
And that's where the secret tunnels that I read about online comes in, I presume. So I saw that, in Disney where Alisa used to work, right? There,
right. So off stage, right?
They call it backstage because we are all cast members. Like this is a show. So like the park is level 1, right? There's another like level below that mimics the park on top.
So it's exactly the same downstairs as it is upstairs, so you don't get lost. You roughly know the
like
direction.
this, like downstairs, this is Tomorrowland.
That's crazy.
Yeah,
That's
and
like
there's secret like
Legend of Zelda.
Areas for you to like ascend.
That's crazy. Is it true that apparently, right? I think someone told me, I think John told me, right, that because Mickey Mouse is a person technically, right? He can only appear once. And nowhere else. So if he's right now appearing at Hong Kong Disneyland, right, he cannot suddenly appear in Tokyo Disneyland.
For
How
the
do they
show.
coordinate that?
I don't know.
there's one guy that's thinking of all these things.
Huh? That's a job, eh?
No, and then is he?
So hospital is not a theme park. It's not Disneyland.
For sure.
Also got secret tunnel.
But we have a whole basement network and we don't ascend magically in. So the tunnels in between, right, you don't see. I think in modern hospitals, you would not notice people pushing carts or linen and bed sheets and things like that, or trolleys or things. Actually, in our hospital, we even have a back set of corridors.
Wow.
So we cook the food in the basement as well, in the kitchen, and it's loaded up. It's like an airline trolley, but it's much bigger than that, right? It's got so many patients' food on it. It keeps the food warm. It goes up behind the back lifts and the back corridors, and then I suppose you see it magically appearing. The AGV comes with the food, and then the nurses and the staff.
It feels more professional than hotels, because even hotels you can see the bed sheets and the linens, but this one you don't even
Yes,
know.
correct.
Is there a reasoning why this system is needed? Like why they can't just push the food out?
Well, part of it is to make sure it's efficient so that we don't crowd clinical areas. We're trying to treat patients, we're trying to see patients, examine patients. You don't want people to be moving things around. Also, there's infection control. So we don't want dirty linen to mix with clean linen. So there's a whole series of, backstage activities that you talked about, like
Makes
in
sense.
your park, but we are a hospital. Not
If people
Disney.
in the wards are like coughing and all, you don't want the food to be passing by, I guess.
I think there is a perception that hospital food sucks.
You should come to my hospital. I think
What do you recommend I try it?
we got Muslim food, Chinese food, we got Indian food, we got different choices, and actually there's quite a right selection. So I've got a whole kitchen and the kitchen team that is part of what we call recovery. So they feel that they're not there just to feed people. They're the kitchen staff, right? The chefs and everyone working in it. They think that they feel that they're part of the recovery and healthcare treatments.
Fantastic.
And
Which
you know how important food is for Singaporeans.
Yes.
Exactly.
So when they are recovering, we want to make sure that the food that they see in front of them makes them want to eat and want to get well.
That's true.
So, but of course, we have to follow follow what the dietary requirements are. And so the dietitians will say, cannot be too much salt, cannot be too much sugar, etc. So it's quite tough.
Yeah.
But the challenge is there to put the tasty meal. So there are many options. And in fact, I do taste the patient's food. Earlier this week, I had lunch with some patients to just to get some feedback about what's going on.
Do they know you're the CEO, or is this like undercover boss?
No, new idea. Next time we try undercover, right?
Yeah, you just be a patient also, like you just
but how many patients find out that they anyway? This month we had a meal with patients to get some feedback directly about the experience, and we ate the food together, and then the patient said the food was quite nice. Yeah.
In the unfortunate situation that I have to be warded, right? Is there a dish I must try?
There's a ayam masak merah with nasi ulam.
Wow.
It's a Malay dish. But that was really nice. And if you can eat spicy food, right? Our hospital kitchen has mixed this sambal belacan.
Wait,
I thought
that's crazy. No, it's so hard to find nasi ulam outside. Now the hospital has nasi ulam. Oh wow.
Okay, but you cannot just be hospitalized just for that.
Don't do that.
So these are all the things that you say, the doctors may not be aware of, or even public may not be aware of, but as part of making us a good hospital that serves our patients well, right? I think we have to make sure all these parts come together.
Okay, then I wanted to ask about codes in the hospital. How do you all decide, right? Like code blue equals this code. Like, is there a meaning behind the coding system?
Code blue is almost international. I think you see this in all TV shows everywhere, right? Because we want to make sure every hospital has the same of these codes. Because, in Singapore, our hospital, especially in public hospitals, our doctors do move around. There's more junior doctors move around. So you cannot say if an emergency in this hospital is blue, in this hospital is green, or in the hospital is red, right? So yeah.
Wait, so what does blue mean?
It's like the patient
turned
dying
blue or something. Yeah, it's a
Right.
crash.
Crash.
The heart has stopped. Yeah, the breathing has stopped. Yeah.
When
So
someone
you need
stops
to
breathing, they turn blue.
Emergency resuscitation. Yeah.
Okay,
we can-
okay.
yeah.
Are there like other codes, and then like what do they mean?
So in our hospital, we actually have something called code V.
Code V.
And it stands for violence. Situations get out of hand. So someone has become aggressive. There's a threat to staff or other patients.
Right.
And it's part of this work that I've been doing with MOH to try and make sure that we prevent unnecessary abuse and harassment of healthcare workers. Is to look at how we respond to such unfortunate incidences in hospital. So in fact, we are in the process of seeing whether we want to standardize this code as well in Singapore. And we're thinking about code grey actually as a
Also, this doesn't exist yet, but except in your hospital.
No, every hospital has their own code name for the
it's not standardized.
So we're trying to standardize it. Yeah. So
What are the most common occurrences of maybe abuse that the staff usually faces?
Yeah, so most common, I guess, it ranges from verbal abuse to insults, and then sometimes even, people making comments to each other and insulting staff. But the worst thing, of course, really is when there's verbal threats to harm staff or to complain about their professionally, or to put them on social media, or even sometimes physical abuse. So, unfortunate incidents where, patients throw hot water or hot drinks at staff when they're upset. So these are unfortunate. We don't wish these happen on a daily basis. It really detracts from our staff's ability to provide good care, because it throws people off, right? I mean, if you're suddenly scolded or you're suddenly attacked, right, then you can't remember what you're supposed to do was, right? And then you have to adjust yourself collect yourself before carrying on to the next patient.
It seems so counterintuitive, because to abuse a care staff or like a healthcare staff who are there to help you essentially.
You say it's counterintuitive, but actually, when we started this work post-COVID, right, when staff in hospitals were complaining about burnout and stress, and then we asked what are the things that contribute. Of course, there were a lot of work issues, but also, a lot of having to deal with very sick patients and COVID. But amongst it, right, this voice came up about them being, harassed or abused by patients or next of kin, or even members of the public, and when they're trying to do their work. Then we actually did a bit more research into it. So actually we did a survey of 3,000 healthcare workers, and we found that actually 2 out of 3 actually would have experienced or witnessed an incident which qualify as an incident of abuse or harassment in the course of 1 year's work. So either they were the recipient of someone scolding them or threatening them or hitting them, or they witnessed it.
Right.
Yeah, so there are many stories of very unfortunate incidents that have come to my attention. I think some of them that's really struck me, one of them really was a case where a healthcare assistant, right, was accompanying patient to have a bath in the shower, in the toilet, right, assisting the patient. And the patient suddenly asked the staff to take off her clothes. Can I see your body? And it's very traumatizing for our staff to suddenly feel this way. And of course, they say no and they have to get out. But you're in a room, in a bathroom with a patient, and you might feel very, very threatened. Yeah. So the suggestion, and whether it's playful or whether it's serious, it's something that we don't accept at all. So this is kind of sexual harassment, which we think patients should be aware. You cannot, this is not funny, it doesn't make joke, and you shouldn't make such comments like that. Yeah. The other thing that comes fairly often is, patients or next of kin filming our staff doing things or saying certain things, then they post it online, actually out of context, and they make a commentary that you say this person has done it in this particular way. And without us having a chance to explain, right? I mean, we do know social media, the good and bad of it. Sometimes things can go viral very fast. And can you imagine if your quote or what you said was taken out of context, and then there's a commentary which is negative to what you say. Watch out for this staff. She's a terrible nurse in this hospital.
They dox the nurses. Yeah. Oh my.
Yeah. Unfortunately, this happens more commonly than you think. And we really don't think this should happen ever again, because basically it's very traumatizing for staff. They cannot work. Yeah. This one, they take days and weeks because they're very worried about who is seeing it and whether it's being spread or not. So I think these are certain examples that we need to draw the line.
It's so crazy. It's like, I mean, at the end of the day, right, like you are told like be nice to wait staff in a restaurant because you never know what they might put in your food, right? This one is your life. Like this is someone who is here to care and potentially save your life, and you want to abuse.
No, I think because they got the Hippocratic, the oath. Like no matter what I do,
we won't. But you cannot. Don't do that to us.
I think they feel like there's no repercussion because you won't kick them out.
Unfortunately, one of the things that CEO has to do in the hospital is actually part of this work. We said that if we need to, we do need to send patients a very stern a warning or even a letter to tell them this kind of behavior is not condoned. So we have a system that we put in place. Again, right, we want to make sure that all hospitals, all healthcare providers follow the same approach. This is the implementation guide. It's a stepwise, sort of kind of like 3 strikes and you're out. So sometimes people kind of think that I lost my temper and then I scolded you and then you went away and it's all over. But we wanted to put it on record that, this thing that is should not have happened. There's many other ways for you to communicate. So a verbal update or warning first, then really that's followed by a letter which the CEO signs, because I need to protect my staff.
Absolutely.
I need to make sure that they can work safely and don't feel that, I come to work, suddenly I may be attacked by someone when, So then I write a letter. And the third thing really, which is hard to do, is to say that this patient, right, we kind of say that this patient, we're going to deny services unless it's emergency. Of course, if you come in and you're in emergency, you're bleeding, you had a heart attack, we treat you. But if you're coming into the clinic and you are demanding for certain things and you are, scolding staff, we advise you basically don't come to our clinic. Go and seek help in another hospital or another clinic in the city, because the working relationship between us and you are broken down. So these are hard things. When you become a doctor and a nurse and a therapist, it's the last thing you think about wanting to do. But we are serious about making sure that our staff are protected. And in fact, when you reduce such incidents, right, everybody benefits. All the other patients benefit too. Yeah, because if an incident happens like this in the clinic, right, shouting, screaming, and then throwing things, right, the whole clinic operations is disrupted for a while. We got the call crisis and things like that, right? And the other patients are shocked. The staff are shocked. And then how are you going to continue seeing patients? It takes a while to calm down, and so that's where we step it up, If you continue to do this, then please don't come here anymore. If it's an emergency, if you have collapsed and you're going to die, of course we will resuscitate and treat you. But don't do this to us. So that's serious stuff. This is one of the things that still worries us. But we hope that, just not talking about it and not doing anything about it doesn't make it go away. So that's why we decided that, let's bring the hospitals together and let's work on something that we can all rally behind, standardize it, and really make a difference.
So like, for example, if I think something that I've seen before in hospitals is like when they're not happy, they were like, like very small microaggressions towards the nurses, right? This kind of thing. Like, is that counted as abuse also?
Rolling your eyes at people or making the sound, or or commenting when behind the staff's back. These are, I guess, not so egregious, but if it continues to become the culture of the way patients treat nurses and doctors, it's not the kind of culture that we want to have in our hospitals in Singapore. It just, we want to make sure we keep it in check. It doesn't continue to get worse and worse. And once you sort of turn a blind eye to this, and then you can make snide remarks at us, and we pretend we didn't hear, then people feel that I can say a bit more, and we don't want that to escalate out of control.
But how do we differentiate from? I think if I were to put myself into the shoes of a patient, right? I go to a hospital, I expect care, right? But of course, at the same time, there's also a respect that's given to the people who are caring for me. But what if I just feel like I'm in so much pain?
We know our patients come to us not because for fun. It's not a theme park. They want to come for treatment because they're sick, and we are there because we want to treat our patients, right? So how do we get this to work 100% of the time, lah? Actually, it does work most of the time, but occasionally it breaks down, right? So what is it, right? So as one of the key areas is about communicating. So I don't know if you've seen part of this work we did was we had a whole public education campaign which says no excuse for abuse. You might be in pain, you may be upset that you're waiting, you may be worried about your relative's condition or your condition, but there's ways to communicate with us. We try and sense when you need help, but you also tell us very early when you're upset, you're frustrated about something. Communicate with us early. Patients and people sometimes get upset when they have waiting too long. So for example, in our hospital, we have a tracking system. In our clinics, for example, if they're waiting to see doctors, our counter staff actually know that there's a dashboard that tells how many patients have been waiting in the clinic for so long, longer than expected, right? And then if for example, if their doctor is delayed, didn't come to the clinic in time because there's an emergency in the ward, they will go up and proactively talk to these patients rather than, get people to get so upset and then they say, I wait so long, how come nobody came and see me? So we try and be proactive about these things. We train our staff to also identify how to best manage patients who are maybe a bit older and maybe a bit confused sometimes in the ward, right? So in fact, there's a technique we teach them to really try and go to eye level, talk to patients, look at them directly in the eye, and then a bit of a comforting touch, and then keep patients to be in as vertical, sitting up position as possible. Actually, you don't realize it that if you are lying down flat on your back, all you see is the ceiling. You cannot hear who is talking to you because you hear voices, and then suddenly someone touches your hand and say, I'm going to take you to take x-ray now. It can be very confusing. So there are many things that we try to do to prevent these things. So we make a big effort. We got patient experience officers. Say, I would like to speak to someone. I feel that something's not been done right. We have patient relations services that where, for example, you feel that clinical judgment is not correct. You want to have a second opinion. All these we have. So if you think your doctor's made a wrong decision, your nurse has done something, we have a whole process that we put in place. Tell us what it is. We'll make an independent assessment to see whether an error has occurred. As a hospital, I hope you will accept that when we say that when we've done something that is wrong, as we have fallen short of what we expect to do, we apologize. We do a disclosure. We tell patients, look, there was a mistake. We are sorry about it. And we will make amends for what we've done. And because we need to recognize this ourselves so that we can make sure that we don't cause a situation like that to happen again. So that's something that all hospitals are committed to do. And I think patients need to know that. And we don't cover up. But throwing things around, insulting people, hurling abuse and threatening, there's no excuse for that.
This is literally relationship advisor. Everything that he just said applies directly to our relationship.
So you hear the patient-doctor relationship, we talk about it a lot, and it's very serious. We think that a lot.
Bring it up early. Don't let it fester.
But of course, when people are in the hospital, it's a heightened situation. Someone is sick, so this is quite serious.
I'm thinking, right? Maybe everybody need a live mood tracker. So when I go to a hospital, then as part of my link, I can live update how angry I am or how happy I am. So
it's
far.
5 emojis.
Then in the ward also, then above me, then you see across got one angry face. Then you must faster.
But people can abuse the system. system.
Or they just keep angry.
No, but at least like, I would think at least 70% of them are being accurate about it. At least that's quite helpful to know that, okay, it's all smiley face. Oh, one person is like straight line face.
Yeah,
now
why,
I know like, I am anticipating.
So everyone should know, but actually I think you should know yourself if you are really angry or upset, right?
I think the difficulty is because most people I would imagine are non-confrontational. So I don't really want to make a fuss until it's like I need to blow my top off, you know?
I understand, but I think it's no harm to bring up issues early on. Really, it's much better.
I know it's probably not gotten away at all, but like since the campaign has started and since all the efforts have been put up, has the number of abuse and violence gone down?
So, I think it'll take some time.
Okay.
What we do know is we have surveyed our healthcare workers, our colleagues, our nurses and all that, feel that are more confident that the hospital and in fact the ministry is behind them and that they feel that, you know, it will not go unnoticed if it happens. We have also asked people to report more. So previously, people say, you know, or nurses say, never mind lah, what to do, over already, right? I feel terrible, but what am I going to do? Report also, what's the point? We're asking people to report because we want to know what happens. So in fact, if you ask, what we do see is more reports are coming up.
Okay.
But it doesn't mean there are more incidents. In fact, we do know when we first did our survey, right, that almost 70% of incidents go unreported because they say over already, nothing can be done about it, so let's don't report it. But we are thinking that we should report it and we should collect more anecdotes or cases so we understand what's happening and we can proactively try to prevent these things from happening. Yeah. So answer your difficult question to ask because you see the numbers going down. Actually, when we look at the reporting, the reports are going up. But we ask people to report more. Yeah.
Is there support as well for staff who faced abuse?
Yes, definitely. That's part of what our work is. So we make sure that every staff who has faced it is immediately attended to.
Okay.
In fact, we need to give them some time off if they are very traumatized because actually, you know, sometimes they can't work. They're shaking because and if they're like that, how can they look after another patient? So you have to give them time off. And if need to, we send them for counselling. And psychological support. We do this both on in-house. We have a team that supports our staff, but also we have external providers if they feel that they're more comfortable talking with an external mental health provider. So this is what we try and do. Yeah.
So just a question to close, right? Looking forward, I think now there are so many AI things coming up also. Are hospitals actually adopting a lot of this AI, you know, I don't know, like, you know, they say the robot do the surgery or these things. You know, see?
No,
So there are robots that can do surgery and we're starting to see whether AI can predict certain things, length of stay, for example, looking at certain characteristics of patients. So
it's the supply and demand planning.
Yeah, correct. So there are many areas that AI can come into work. Clinical care, whether making clinical decisions is a bit further off, but definitely it's an area that we're trying to figure out what's the best approach to this because I suppose making a clinical decision is a very serious one and we do know that there are certain risks to letting AI make those decisions.
Absolutely.
Yeah.
Absolutely.
So, but there are a lot of things that we can work on. We do have a trial robot in one of our, we call it our smart ward, our innovation ward, and we pre-programmed it to do a lot of things for patients. A lot of it is about orientation. So, you know, I don't know why, I guess if you were hospitalized or you brought someone to a hospital, in the first hour or so, the nurse will come and tell you, this is your bed, this is the call bell, this is what you do, the toilet is down there, this is what you're...
Yes!
A lot of things like orientation, right? Then after that you forgot what they said, right? So in fact, one of the things the robot can do is come back and say the whole thing again. You forgot, right? That's one thing to do. Then
free up the nurses to do more critical roles.
And
this robot at the dementia ward gonna be very busy.
But very useful.
Exactly. And then the other thing, of course, is again, sometimes patients try and help themselves too much when they shouldn't. So for example, they try and get out of bed when they shouldn't and they fall down. So the robot will go around again telling people that please remember, don't go out of the bed on your own because you are at risk of falling. If you need to, please call us. That's your call bell. Please press it.
Yeah, but I was also reading like how like a lot of these humanoid robots, right? They don't want to make them too strong because if they do end up taking over, right? At least there's a way for you to like
Outfit,
beat them essentially. So that's why a lot of them are actually of the, I think 70% strength of a human adult. So that you can actually take them on.
I see.
Okay, so we've come to the end of the episode. A big thank you to Dr. Chua for joining us today and
Thanks for
sharing
joining us.
all his knowledge with us. I think one of the more serious things that we did touch on was abuse in hospitals. And I think everybody does have quite a shared responsibility when it comes to creating a healthier hospital environment, pun intended. So there's no excuse for abuse, like Dr. Chua said.
Yeah, and actually, if people want to know more about the campaign that we do and all the work and more stories about what we talked about, this serious stuff, you can just search "No Excuse for Abuse."
Okay, maybe we just put a link down here so you can check it out for more information. Like, share, subscribe. We'll see you in the next one. Bye-bye.
Bye.
This has been in the newspapers before, but we call it Gardens by the Bed.
Oh my god.
Okay.
Who come out with this?
So we realize patients again are stuck in the bed, right? They're recovering, they cannot go out. So our therapists, our occupational therapists actually bring little plants from the nursery, and when you sit out of bed, as part of the therapy, we ask you to do some bit of gardening. So there's literally gardens by the bed. And again, it's keeping patients not lying down the whole day, sitting up and doing something that's a bit meaningful, connecting them to nature, encouraging them to get well. So
Why is got one patient like the plant keep dying?
we replace it with another one.
When they sleep, right, like you must change.